So as I'm sure your listeners know, hidradenitis is a chronic inflammatory skin condition that primarily affects the groins and armpit and causes boils. There are a number of reasons why somebody with HF might ultimately come to the emergency department. If they're not plugged into longitudinal care with a dermatologist or other provider, then they might seek out the emergency department because they're not sure where else to go.
That's Dr. Alexandra Charrow, and this is Dermatology Weekly, the weekly podcast from MDedge Dermatology. I'm MDedge editor Elizabeth Mechcatie.
And I'm MDedge editor Terry Rudd. Today, hidradenitis suppurativa literature has expanded in the last few years, but there's still a delay in diagnosis for most patients because of a lack of familiarity with the condition. Dr. Vincent DeLeo talks with Dr. Alexandra Charrow about treatment recommendations based on disease severity and recommendations for patient lifestyle modifications.
In the news, how the safety profile for the biologic certolizumab varies by disease, and a pilot study illustrates some differences in the way naturopathic and allopathic practitioners approach atopic dermatitis.
You can reach Dermatology Weekly by emailing us at podcasts@mdedge.com. You'll also find that email address in the podcast description.
And now the news.
The risk of serious adverse events associated with certolizumab varies considerably depending on the disease being treated. But systemic corticosteroid use and obesity have a big impact. A multidisciplinary expert panel convened by certolizumab's manufacturer analyzed serious adverse events in the TNF inhibitor's 49 clinical trials. Dermatologist Dr. Andrew Blauvelt is president of the Oregon Medical Research Center in Portland. Dr. Blauvelt was also on the expert panel and presented results of the analysis at the annual Congress of the European Academy of Dermatology and Venereology. The panel's takeaway, according to Dr. Blauvelt, when thinking about certolizumab's serious side effects, consider the disease being treated, whether a patient is on systemic corticosteroids, and whether they're heavy or not. Take, for example, the risk of serious infections requiring treatment with IV antibiotics. The incidence rates range from a low of 1.5 per 100 patient years in psoriasis patients on certolizumab to a high of nearly 6 in those with Crohn's disease. Why the high variability? Dr. Blauvelt says the explanation lies in part on the huge differences in the concurrent use of systemic corticosteroids with certolizumab. 3% of psoriasis patients were also on steroids, compared with 46% of rheumatoid arthritis patients and 51% of those with ankylosing spondylitis. Obesity alone wasn't an independent risk factor for serious infection, but the combination of a BMI of 30 or more plus systemic corticosteroid use was linked with a greater risk than with steroids alone. The incidence rate for all malignancies, including non-melanoma skin cancer, varied. It ranged from a low of 0.46 cases per 100 patient years in the psoriatic arthritis cohort on certolizumab to a high of 0.9 in those with rheumatoid arthritis. The rate was 0.7 in patients with psoriasis. Neither systemic corticosteroids, obesity, disease duration, nor prior exposure to a TNF inhibitor was linked to increased risk of cancer in patients on certolizumab. The standout risk factor was age. Patients who were 65 years or older at baseline were 11-fold more likely to develop cancer during a certolizumab clinical trial than those younger than 45. Those who were 45 to 65 years old were 4-fold more likely to be diagnosed with a malignancy than were those younger than age 45. We'll be right back after this message.
Allopathic and naturopathic providers use similar strategies to diagnose atopic dermatitis in children. But when it comes to treatment, they diverge in their approaches. Those are the main findings from a survey of 30 allopathic and 21 naturopathic providers who answered questions about atopic dermatitis. Dr. Julie Dasch is with the Department of Dermatology at Oregon Health and Sciences University in Portland. She and her co-authors point out that previous studies show that more than half of atopic dermatitis patients have used complementary and alternative medicine in addition to allopathic care. But those providers may not be aware of each other's treatment approaches, and that can be confusing to patients. Allopathic and naturopathic providers alike recommended skincare protocols involving moisturization and soak and seal bathing. But while all of the allopathic providers said they'd prescribe topical corticosteroids for mild to moderate disease, only 19% of naturopathic providers said the same. Half of the naturopathic providers said they would choose topical botanicals, oils, or a probiotic as first-line treatment for mild to moderate disease. In contrast, none of the allopathic providers said they'd take that approach. Of note, 85% of naturopathic providers said they thought diet had a probable or definite role in atopic dermatitis, compared with only 3% of allopathic providers. And more than half of the naturopathic providers recommended dietary changes, such as removing potential food allergens, reducing sugar, and emphasizing an anti-inflammatory diet. Despite the study's small sample size and other limitations, the authors say their results provide evidence of differences in treatment approaches between these providers, and they add their findings suggest that respectful collaboration between allopathic and naturopathic providers will help practitioners find common ground, decrease patient confusion, and improve patient outcomes. The study was published in Pediatric Dermatology.
And now, Dr. Vincent DeLeo and Dr. Alexandra Charrow.
Today we're talking to Dr. Alexandra Charrow about hidradenitis suppurativa. Dr. Charrow is from Brigham and Women's Hospital in Boston, Massachusetts. Thank you for joining us today, Dr. Charrow.
Thank you so much for having me, Dr. DeLeo. I really appreciate the opportunity.
So let's start. What symptoms may lead a patient with HS to go to the emergency department?
Yeah, that's a very good question. So there are a number of symptoms that might lead a patient to go to the emergency department for better or worse. So as I'm sure your listeners know, hidradenitis is a chronic inflammatory skin condition that primarily affects the groins and armpit and causes boils and large nodules as well as abnormal scarring to form in those areas. Many of the lesions can be very painful, can drain purulence or pus from the areas, and can be very difficult for patients to manage at home. So there are a number of reasons why somebody with HS might ultimately come to the emergency department. If they're not plugged into longitudinal care with a dermatologist or other provider, then they might seek out the emergency department because they're not sure where else to go. As I alluded to in the article, there are many patients that don't know that there is a name for this condition or that this condition has chronic treatment that might prevent flaring, and so they may seek out the emergency department because they think that they just get these lesions for whatever reasons. And then some patients will seek out the emergency department or inpatient admissions because they have very severe flaring of their disease. They're well connected to dermatology. However, because the disease is a relapsing and remitting disease with many episodes of flaring, they might find that they have a very significant flare that's too painful or complicated or is draining too much for them to manage at home, and so they come to the emergency department with the hopes of achieving better control either through antibiotics or prednisone or pain management, depending on how severe their lesions are. Sometimes they might find that surgical intervention is beneficial, although I think that that's often a temporary help for patients and is not usually what they find to be the best long-term care.
That's great. Now, let's talk about the workup of some of these patients. You write about assessing for severe infection in individuals who come in. What should be done with those patients?
So hidradenitis is a complicated condition because it is a chronic inflammatory condition, and for that reason, patients will often have labs that mimic an infection. And so I will very frequently get labs on these patients when they're coming for an outpatient visit as chronic monitoring for whatever medications they're on, and we'll regularly see that patients have very elevated white counts, have elevated platelets, have an elevated CRP and ESR, and the literature has found similar laboratory findings. So it is very common for patients to have white counts in the 10s to 20, so often in the 13, 14, 15 range for a white blood cell count, or platelets in the 3 to 500 range. And so when a patient comes into the emergency room with hidradenitis and they have those lab findings, it behooves us to really consider evaluating the patient to ensure that what we're seeing isn't simply a sign of chronic inflammation. Moreover, even if the lesion is draining purulence, and even if the lesions are growing in bacteria, that is not suggestive necessarily that the lesions are themselves infected. Because of the location that they're in and because of the pathogenesis of hidradenitis, it's very common for the lesions to be chronically colonized. And so in order to determine if somebody has an acute infection, it's most helpful to think about their constitutional symptoms and see if there's been a significant change in laboratory findings or laboratory abnormalities. So if somebody's white count is generally speaking 13 and they come in with a white count of 20, that might be more suggestive of an infection than if they come in with a white count of 14 and their baseline is 13. If a patient usually notes some mild or low-grade fevers with their flaring, which is also not out of the ordinary, but they have a fever of 102, and generally speaking, they have low-grade fevers or temperatures in the 99 range, that will be more suggestive of an infection. This becomes further complicated because a lot of patients who have hidradenitis are then immunosuppressed, so they are on Humira or they're on infliximab, and in those situations, it can be really difficult to tell if they have an infection or if they have inflammation. We tend to cover these patients with antibiotics, but for the most part, there hasn't been a lot of evidence to suggest that they actually are having an acute infection for the most part.
That's great, because that is a confusing issue with these patients who have very severe disease and come in with systemic symptoms. So you note that there typically is a delay in diagnosis of HS of all stages. Can you explain why you think that is?
Yeah, I think there are many reasons why there's been a delay in diagnosis. So I think for a long time the condition was not at the forefront of the priority of most specialties, whether it be dermatology or OBGYN or emergency department or surgery. And it wasn't, I think, until the Pioneer study came out that it became clear that there were systemic agents that might be available for hidradenitis outside of long-term antibiotics. And I think that really changed the landscape, and since that time we've seen an explosion in the literature on hidradenitis. But prior to that, there really wasn't that much out there, and you can actually see as you track the literature that now there are thousands of papers that come out every year on hidradenitis, when there used to only be 50 to 100 every year, which is really quite striking. So I do think that increased focus is helpful, but you could imagine that there's a lag in terms of the amount of information that's available, not only to dermatologists, but to the people at the front lines who are seeing this condition primarily. And those people are primary care doctors, emergency medicine doctors, OBGYNs, and surgeons. And if they don't know about hidradenitis, or they are not familiar with all of the different therapies that are out there, they might not give the patient a proper diagnosis. And so we find that patients have a very long lag time from when they come into all of these different specialists and to the emergency department and the time in which they're given a definitive diagnosis. That has certainly changed over time, but I do think that it's for that reason, because there wasn't a lot of focus on the condition for a variety of reasons, and because of the potentially lack of education about hidradenitis that's given to some of these other specialties. I think there are lots of reasons that many physicians and researchers are looking into as to why there might have been a delay to begin with, or a lack of focus. The condition primarily affects people of color, it primarily affects women, it primarily affects overweight and obese patients. And so you could imagine that there's sort of a marginalization of that patient population. There's been a lot of good research by Haley Nyack out of UCSF that suggests that patients really do feel marginalized and not taken very seriously by the medical community. And so sometimes they themselves will seek out other treatments because they feel like they're being blamed for their condition. So I think that all those things in combination are likely contributing to a delay in diagnosis and treatment for patients. But I'm really optimistic based on the more recent explosion of data that's emerged over the past few years, an increase in renewed energy and interest in hidradenitis, and I think the outreach to the community that's been occurring over the past few years. I've seen a lot of patients that have come into my clinic that have seen advertisements on television. I'm not sure who's putting out these advertisements, but they're seeing advertisements on television and they're recognizing their own symptoms in those advertisements and coming in to see me for that reason. And I have to say that that's been very helpful in me seeing patients who've never seen a dermatologist. So I've seen many, many patients who had never seen a dermatologist or had never seen any doctor for this condition in my clinic.
I've also noted, I think, in our own clinic here that we're seeing a greater interest, and patients are much more aware of what's going on with their conditions. Now, one of the things that has developed is a staging system called the Furley staging system for hidradenitis. Can you explain that for us?
Yeah. So the Furley staging system was actually initially developed for surgical staging, but it's the most commonly used staging clinically, and it's tied to the use of a lot of the newer biologic medications, and therefore I have found that it is used very frequently in both the literature as well as in the clinical setting. And it's divided into 3 stages. There's Furley stage 1, 2, and 3. Furley stage 1 is isolated nodules or isolated abscesses. Furley stage 2 is wider areas that are separated by sinus tracts or scarring. And Furley stage 3 is where there's essentially a diffuse area of injury in which there's very little normal skin separating one sinus tract from another scar from another nodule or abscess. There are other scoring modalities, so there's the high scar and a number of others. However, those are primarily used for clinical trial settings.
That's great. One of the really impressive things about your article is the table where you use the staging system and recommend management of patients in those stages. So can you take us through that? By the way, I think everybody should download that table and keep it with them when they're in the clinic and seeing patients like the ones we're talking about today. So can you talk about the table and the management of patients depending on the severity of their disease?
We divide it up into the different Furley stages as well as people who have scarring without any active disease. And the reason why we do that is because there are a number of lifestyle modifications people can use to prevent themselves from getting further flares that run across all population types regardless of Furley stage. So if somebody comes in and they have a history of hidradenitis, they don't have any evidence of HS today, or they just have an evidence of a few scars, then you can still discuss lifestyle modifications with them. And we usually run through a number of lifestyle modifications with patients that can be beneficial before we even get to some of the treatment options. So for patients across the board, we recommend, with respect to lifestyle modifications, smoking cessation. Nicotine specifically has been demonstrated to cause significant inflammation in hidradenitis, and so if they're going to quit, I'll sometimes recommend Chantix or other medications that are not nicotine replacements because those could also aggravate the disease. We will also recommend specific hair removal strategies. So I recommend that patients avoid shaving, plucking, waxing, or nair, or any other hair removal strategies that will cause regrowth and the possibility of a patient developing an ingrown hair. If patients are really unhappy with hair growth in the area, then laser hair removal can be beneficial and has shown some success for certain patient populations in terms of treating their HS. We'll also recommend specific birth control modalities that are less inflammatory for patients. So in general, the progestin-only forms of contraception as well as first-generation oral contraceptives are quite inflammatory for patients with hidradenitis. So I recommend against the Depo, Nexplanon, mini pill, or any other progestin-only contraception. Mirena and Skyla are controversial, although we have found that patients have flared when they've had these modalities as well, despite the very low levels of progestin in these products. And instead, we recommend that they be on a second, third, or fourth generation progestin oral contraceptive, and that's usually Yaz or pre-sodrospiridone or some of these other forms of progestin. And then there are other lifestyle modifications, sweat management and clothing, making sure the clothing is not too tight when they're wearing it. And for sweat management, we'll often recommend clinical strength antiperspirant or sometimes aluminum chloride if necessary in order to help prevent flaring of the disease. There are lots of diets that are out there that people will try with variable success. Obviously, weight loss has been demonstrated to be beneficial for a large group of patients, although I do have a cohort of patients who've undergone gastric bypass and have found that their disease is worse because they have more redundant tissue now. But in general, with respect to specific dietary limitations, we haven't found in the literature that there's any specific limit to the diet that has been helpful, although many patients will anecdotally say that when they avoid sugar or nightshades that they do have improvement in their disease. Whey protein, as with acne, has some inflammatory sequelae, and so we'll sometimes recommend that patients avoid whey protein as well. So that's all lifestyle modifications. And then there's disease severity-specific initiation of treatment. So for early stage 1, when patients are flaring, we can usually control the flare with a short course of antibiotics. But even the Hidradenitis Society or Foundation have noted that short courses of antibiotics are likely not going to change the overall course of the disease. So for patients who have early stage 1 disease who we want to be on longer-term therapy to prevent further flaring, we'll usually have them on a longer course of antibiotics, usually a tetracycline for 3 to 6 months. They can consider acitretin if they're a man or a woman who's past childbearing age, or if they have a particularly comedonal disease. And then we'll often add low-dose spironolactone based on Dr. Kimball's paper because we found it to be quite beneficial and has very low side effect profile for women. In terms of early stage 2 disease, that's where we start to think about other stronger agents that might be more helpful. So this is where spironolactone and tetracycline in combination can be helpful, but we consider adalimumab or Humira at this point for patients with stage 2 disease, depending on how well they've done on the other agents. We can also add a short prednisone taper if they're flaring and have stage 2 disease, or a short course of Augmentin or other antibiotic as necessary. But again, the short courses of antibiotics don't demonstrate as much benefit as longer courses of antibiotics or Humira or spironolactone. Some patients do find that clindamycin and rifampin is helpful here, and the evidence is quite good. For younger women, there's a lot of med-med interactions with the rifampin, so I prescribe it a lot less often than I would like, and the clindamycin can sometimes be a little difficult to tolerate, but for a 3-month course, it has shown great efficacy in the literature. And then for early stage 3 disease, in addition to some of the medications that we've recommended for early stage 1 and stage 2 disease, we'll also consider other medications if they have failed Humira. And this is where it gets tough because, as I've said to many insurance companies over the phone when I'm fighting for these medications, there is only one medication that has been FDA approved for hidradenitis, and that's Humira, and only 50% of the patients in the Pioneer trial demonstrated significant improvement, which means that there's half of patients who have no FDA-approved treatment for their disease. And so when the Humira fails, we are reaching for things for which there's no FDA approval, but for which there is some pretty good evidence. And so I'll often start with infliximab, which is a very, very good record in the dermatology literature. I'll start at 5 mg per kg, although there's been more recent data to suggest that you could start as high as 10 mg per kilogram and space it out every 4 to 6 weeks if you wanted to be aggressive. For under a year, you could have somebody on cyclosporin, and we have had a few patients on cyclosporin with some control of their disease. But then outside of those treatment options, outside of the infliximab and cyclosporin and Humira, you're starting to get into treatment options that have less evidence for them. So IL-1 inhibitors such as anakinra or canakinumab have been used and documented in the literature. There are a few more treatments that are starting to emerge in the literature in combination with Humira. You might add methotrexate or other treatments like that. But it gets very challenging once you're in the early stage 3 disease and you've gone through all of the evidence-based treatments.
That is really a marvelous look at the algorithm for treating patients depending on their disease states, as well as for chronic control of all patients at all stages. I really think that everyone should have a copy of your table because it just actually lays out everything you just said. It's really impressive what we've learned about this disease in the last, say, 5 years, I guess.
Yeah.
Would you agree? I mean, it's truly amazing.
It's really impressive to see how many new treatments are available and how much the literature has expanded. There are 20-plus clinical trials that are ongoing in the United States for multiple different avenues of study of this disease, which is really exciting to think that in the next 3 to 5 years, it won't just be one FDA-approved medication for hidradenitis, but that there are likely to be multiple FDA-approved medications for it. I think that this is one of those times when the fact that this disease is actually so common, it really helps the patient population out. I think there are many diseases in dermatology that are rare, and it can be very difficult to find evidence-based treatments, but hidradenitis is very common, and even severe hidradenitis is common enough that I think we're starting to be able to recruit patients across multiple sites for multiple trials.
This has been a really amazing discussion with you, and we thank you for spending the time with us, and would recommend that all of our listeners go to your article and particularly to your table. The other thing I think that you brought out, which is truly important for care of these patients, are the lifestyle changes that you recommended. And I think sometimes we forget about those when we're in a busy clinic or even in places like the emergency room. So is there anything else you'd like to add? It's really been a wonderful discussion.
Well, thank you so much. I really appreciate you having me on. I could talk about hidradenitis all day, as you might be able to tell. I think other than the various lifestyle recommendations that I went through with you, I do think there are a few other things to sort of consider with all patients. The data from Dr. Nayak has suggested that these patients really have a high psychiatric and psychological comorbidity profile, and I think that many other studies have demonstrated that as well. And so I would say that in addition to all the lifestyle modifications, I often try my best to ensure that my patients feel safe and that they feel like the disease, even if it's not well managed, that they have an outlet should they be having worsening depression or feeling really isolated, because the disease can be exceptionally isolating for patients. Many patients find they can't work, they can't live normal lives, certainly they can't have normal sexual lives because of where these lesions are located on the body. And so I think it's helpful to be mindful of just how stigmatizing this condition can be for patients and to be patient with them. And it is tough, as you pointed out, because we're in these very busy clinics. So I try if I can't get to everything at one visit to have patients back if they're not traveling from too far away, and have a lot of patient handouts that I provide to patients in case they have questions that they forgot about or things that they wanted to address later on that deal with some of the lifestyle modifications and with referrals to surgery and who they should call and when in case they need to. I'd say as a sort of final point of discussion, I do think that large surgery with plastic surgery, so surgery that removes the tissue in its entirety, can be helpful for patients who have really severe localized disease. And so that is one thing that I'll keep in my back pocket for patients who have very, very localized but very severe disease as a curative option for patients.
Incredible discussion, and thank you for giving us your time today.
Of course. Thank you for having me on. I really appreciate it.
And that concludes this week's episode of Dermatology Weekly. To get past and future episodes of Dermatology Weekly, subscribe now on Apple Podcasts or wherever you get your podcasts. I'm Terry Rudd.
For Dr. DeLeo, MDedge editor, Melissa Sears, and all of us here at MDedge, I'm Elizabeth Mechcatie. Thanks for listening.